Okay, so today we're going to be placing a lumbar epidural, and so before I even go in and meet my patient and her husband, I just want to go over some contraindications before we go and talk about risks and benefits. So an absolute contraindication for this would be patient refusal. She has asked for it, and so that was not the case. Some relative contraindications would be uncorrected coagulopathies, as well as any infection at the site, which she has neither of those, and so we're going to go ahead and proceed. So I'm going to go and meet my patient and her husband. Good evening, my name is Marley. I'm going to be your SRNA tonight, placing your lumbar epidural. Can you tell me your name? Okay, great. So I've identified my patient. And so I just want to go over some risks and benefits and alternatives for this case. So an alternative would obviously be to just not have the epidural and just proceed with your natural labor. And so I'm going to talk about your risks and benefits for this. So the benefits would be pain control throughout your labor while allowing you to stay awake and be awake for the birth. Some risks for this is I can inadvertently go a little bit too deep with my needle and cause what's called a post-sterile puncture headache, which can be pretty severe at times and last quite a while. And so another risk for this would be if I were to go a little bit too deep and dose that space with this medication, it could travel higher than we would like it, and so that can be also dangerous. And so another risk is very rare. It is a permanent nerve damage, but it only occurs 1 in every 10,000 cases. And so I will do my best to mitigate any of those risks and proceed as safely as possible. So do you have any questions about any of that? No questions. We have a good consent, so we're ready to go ahead and get them positioned and ready. Okay, so I'm going to go ahead and put my gloves on. I'm going to have you just scoot back to the edge of the bed for me and then prop your legs up on a chair. That will just help me. I know it's kind of hard right now, so just do the best that you can. And so I'm just going to feel your hips, and so I'm feeling the top of the iliac crest, and I'm going to go across. This is called Tufier's line, and so the space that I'm looking at is ideally L2 to L4 depending on the literature, what you read, but on this patient it's going to be about right here. I'm also feeling up and down her spinous processes in between each one to get a good feel and ensure that I'm going into the right place. And so I have identified that. I would mark it with make an indentation in her skin with either a CAD key or a surgical pen, and so that has been marked. So at this time I'm going to take my gloves off, don my mask, and get everything ready that I need. So I'm going to, for PPE, I'm going to have my mask, my hat, and sterile gloves, and then also my kit is the only other thing that I'll need for this. And so I'm going to go ahead and open my kit so it's ready to go once I'm sterile. I'm going to use this as a little trash. Okay. Go ahead and put these on. Ow. Okay, get that out of the way. So I'm going to go ahead and get her all sterile. So we're going to be using betadine. I'm going to pour that in my little tray. Clean inward out, 3 sponges. Okay, we're good there. So while that's drying, I'm just going to get some stuff set up. First, I'm going to draw up my 1% lidocaine for my skin wheel. So I'm just going to draw it up with a blunt needle since it is glass. And there's a couple different vials in here, so I'm going to double check that it is 1% lidocaine. So draw that up, switch it over to my 25 gauge needle. Have that ready, and now I'm going to drape the patient. Okay, do my skin wheel. So I like to go in at an angle first, aspirating and injecting, and then I'm going to go ahead and just go right in, aspirating and injecting as I go until I meet a little bit of resistance. Then I will remove the needle. Okay. Okay. And so now I'm going to grab my Tui needle, making sure the stylet is in. Bevel is up, and I'm just going to go in that same, this is also a 9 centimeter, and so I'm going to be paying attention to that as I'm going into the space. So I'm just going to go in at the same way that my finder needle per se did. So that's 2, 3, okay, so I have some resistance there. So at this point I can let go of the needle. I'm going to remove the stylet. The patient is not moving around. If she's moving around, then I really shouldn't let go of the needle. So at this point I'm going to draw up saline into my loss of resistance syringe. Again, double checking the vial to make sure that it's the right one. I'm just going to draw up all 5. Remove that. With the bromage technique, I'm going to advance the needle, not necessarily push with the syringe, as I'm entering the skin. Feeling for that loss. And that did occur at around 5 centimeters. So I'm going to take this off, and I'm looking for any free flow of CSF. That would indicate I'm too deep. I did see a couple of drops of saline, and that's normal, and it is not CSF. So at this point, the epidural space was at 5 centimeters. So now I'm going to thread my catheter. So I anticipate to go about 6 centimeters beyond where I've got loss of resistance. So it's threading fairly easily. And so that is about 10 centimeters. And so for this, I'm going to try to go at about 15 or 16. So whenever I remove the needle, then it'll be at about 10 centimeters at the skin, meaning 5 centimeters into the epidural space. Okay, and that's about it right there. So I'm going to go ahead and remove this. Okay, and then while feeding forward pressure, I'm going to remove the needle very carefully. And looking at my epidural length right here, making sure that it's about 10 at the skin. So at this point, I'm going to get ready to do my test dose. So I'm going to attach this onto here. Okay, and I'm going to draw up my test dose. So my test dose is going to be 1.5% lidocaine. It's going to be 3 milligrams. and it'll contain 45 milligrams of lidocaine and 15 micrograms of epinephrine. And so at this point, the sterile part is over, so I just adjusted it a little bit. And so I'm going to ask the patient as I'm administering this if she feels any numbness and tingling around her mouth, ringing in her ears. I'm going to be watching the monitor, listening for any increases in blood pressure, heart rate. She does have a pulse ox on at this time and blood pressure cuff, so she's being monitored as well as a pulse ox. So I'm going to go ahead and draw that up 3 mils. And so if it's intravascular, from the epinephrine, I'm going to see the increase in heart rate and blood pressure. Intravascular from the lidocaine is the numbness and tingling around her mouth and the ringing of the ears, dizziness. And so if I'm in the interthecal space from the lidocaine, she's going to feel like she's peeing her pants. So I'm going to be monitoring her through this and asking her these questions as we go. Okay, ma'am, I want you to let me know if you're feeling any numbness and tingling around your mouth, ringing in your ears, if you feel like your heart is racing, dizzy, or if you feel like you're peeing your pants. And so first is I'm going to aspirate. And so that is negative for CSF, and so I'm just going to administer the test dose. And she is not showing any of these signs. And so at this point, I'm going to, so she's negative test dose, so I know it's in the right place, so I'm going to go ahead and secure it. So I'm just going to maybe loop it a little bit so that it's out of the way. Place this like so. And I'm going to get ready to do my bolus. Well, first I will maybe take the drape off. Okay. So, just going to secure this up her back. Just the best that I can. Normally I would tape this all the way up her back to ensure that it doesn't come out, and place a tegaderm over this. And so for the bolus dose, I'm going to be using 0.25 bupivacaine. It's going to contain 8 mils of the bupivacaine and then 2 mils containing 100 mics of fentanyl. And so I'm going to administer that over 10 to 20 minutes, 2.5 mils about every 5 minutes. And so I'll administer that, and then also while monitoring her blood pressure, comfort level, and making sure that there are no signs of decline or any issues. And then once that's through, I'm going to administer her infusion, which is going to be 0.125 ropivacaine, and it's going to be 8 milliliters per hour, with the ability for her to give herself a bolus dose of 8 milliliters per hour with a lockout of 16 milliliters per hour. And so then I don't anticipate having any problems with this. And within the infusion, there's also going to be 3 mics per mil of fentanyl. So I think that's it. And then chart. Document where I'm at the skin and in the intro into the epidural space.